Hi, everyone. Welcome to Genetics Unveiled Understanding, Testing, Counseling, and Family Conversations about DM2. My name is Annalise, and I am an intern at the Myotonic Dystrophy Foundation. Gabe Kringlen is a licensed and board-certified genetic counselor at the University of Iowa Healthcare, where he provides clinical care to adult patients and families affected by inherited cardiovascular and neurologic diseases. After graduating from the Northwestern University Feinberg School of Medicine's Genetic Counseling graduate program in 2017, Gabe spent 2 years with Sanford Health in Fargo, North Dakota, where he provided clinical genetic counseling services in a pediatric and general genetics clinic. In late 2019, Gabe returned to his home state of Iowa and began his current cardiology neurology split position at the University of Iowa. As part of his current role, Gabe works alongside neurologists, cardiologists, and other healthcare professionals to provide care for patients and families with myotonic dystrophy and other inherited neuromuscular diseases. In his spare time, Gabe enjoys playing and coaching basketball, traveling, and playing music. Now, please give a warm welcome to our presenter, Gabe Kringlen.
All right. Thank you so much for the kind introduction. My talk is going to be about genetics and genetic counseling, understanding, testing, counseling, and family conversations about myotonic dystrophy type 2. All right. And then just to clarify, I have no disclosures at this time. All right. So I'm guessing almost everyone here is going to be an expert with myotonic dystrophy, at least in terms of having a lived experience, either you or a loved one on having this condition. But just to catch everyone up to speed, myotonic dystrophy, both types, refers to a rare and inherited condition that's associated with progressive muscle weakness, myotonia, heart problems, and other clinical features. So we all know that there's two different types of myotonic dystrophy, type 1 and type 2. I think that type 1 seems to get a little bit more attention, and I think many of you can probably relate to that, feeling like this is maybe one of the little bit more forgotten types of myotonic dystrophy. But we're here to make sure that we try to avoid that from as much as we can. So both types have fairly similar signs and symptoms, with some exceptions that we'll explore today. And we used to think that type 1 was quite a bit more common than type 2, but I think more recent data has shown that might not actually be the case. They might actually have fairly similar prevalences globally. Now, it really depends on the specific population that we're talking about in terms of your ancestry, countries of origin. If you are German, Polish, or Finnish ancestry, there actually might be some data that shows that type 2 might be just as common, if not even slightly more common than type 1, which I think is relatively new data. Other ancestries, it might be reversed, where type 1 is quite a bit more common than type 2. But if we think about the overall global prevalence of myotonic dystrophy type 2, it's probably pretty darn close to the prevalence of type 1. Now, does that refer to the number of people that have been formally diagnosed? Probably not. I don't know if there's data that shows this, but if I had to guess, I think that there's probably been a greater percentage of people with type 1 that have been diagnosed compared to type 2. So both types of myotonic dystrophy, as I mentioned before, the age of onset, severity of symptoms, and progression of symptoms, it can vary quite a bit, not just with type 1 as we've seen, but also with type 2. But overall, I think it's fair to say that, generally speaking, the average case of type 2 myotonic dystrophy tends to be a bit milder in terms of symptoms compared to the average course for type 1. Of course, there's lots of exceptions and variability when it comes to that, but generally speaking, it's slightly milder on average. All right, so let's get into the nitty-gritty of genetics. I've highlighted chromosome number 3, and the reason I've highlighted this chromosome is because this is the chromosome that happens to contain the CNVP gene. And this is the gene that is impacted in families with type 2 myotonic dystrophy. Right, so just to point out, just like with type 1 myotonic dystrophy, this involves a gene that's located on one of what we call the autosomes. Autosome is just a term that refers to any chromosome that is typically equal in number between males and females. So really it refers to all the chromosomes shown here that are given a number. The only chromosomes that are not autosomes would be the X chromosome, so the X and Y chromosome. So as many of you probably know, type 2 myotonic dystrophy impacts males and females with equal prevalence. Type myotonic dystrophy, this form of myotonic dystrophy is associated almost exclusively, if not exclusively, with symptom onset in adulthood. But we don't see any sort of congenital or young childhood onset symptoms in this condition. And again, the symptoms tend to be, on average, a bit milder, and the pattern of muscle weakness might be a little bit different. You might have a little bit more distal muscle weakness early in the disease, meaning weakness in the muscles that are further away from the center of our body. Those tend to be some of the muscles, especially the fingers and the calves. Those can be some of the earliest muscles that are affected in this condition. All right, so just like with type 1 myotonic dystrophy, type 2 myotonic dystrophy is caused by a specific type of genetic change. Instead of a triplet or a trinucleotide variant, meaning 3 letters that are copied over and over again, which is the case for type 1, there's a CTG repeat that is copied over and over too many times. It's very easy to remember because the repeat that is expanded in type 2 myotonic dystrophy within this CMBP gene is a tetranucleotide repeat, so tetra for 4. And it's almost the same repeat as in type 1, except there's an extra C at the very beginning. So it's CCTG instead of CTG. And what happens in type 2 myotonic dystrophy is that there is an excess of these repeats in one of a person's 2 copies of this gene. And it's having too many of these tetranucleotide repeats, or DCTG repeats, beyond a certain threshold, which we'll get to, which causes myotonic dystrophy. A little bit deeper comparison between the 2 types. Again, the age at onset with type 1, it really spans the entire lifespan from birth to late adulthood, and largely, but not entirely, depends on the specific repeat number that somebody has. So unlike type 1, type 2 myotonic dystrophy, average age at onset is typically early to mid-adulthood. The average age is probably around age 30, where you start to have some weakness, but again, that varies quite a bit. However, this is where there's an important difference. The specific number of repeats that somebody has in one of their 2 copies of this gene, it really doesn't matter much at all. We know that the number of repeats can vary quite a bit in people with myotonic dystrophy type 2 within the same family unit, but there doesn't seem to be that same correlation between how much larger your repeat is in the age at onset of symptoms. Why that lack of correlation exists, I don't know if anyone has fully figured that out yet. And that is why they don't necessarily specify the specific size of a repeat on a genetic test. And just to clarify, the gene for type 1, DMPK, is located on chromosome 19. Gene for type 2, again, is located on chromosome 3, called CMBP. Normal CTG repeats in type 1, normal meaning not causing disease, and not being unstable, meaning it couldn't expand when passed on to the next generation. Any number that's less than 34 repeats for type 1 is a quote-unquote normal gene copy that is not going to cause disease in that person and is not going to potentially cause disease when passed on to the next generation. With type 2 myotonic dystrophy, the normal number of repeats is less than 27. Again, that number can vary quite a bit, and it's pretty common for people without myotonic dystrophy to have 2 different gene copies that might have different numbers, but as long as both numbers are less than 27, that person is not going to develop signs or symptoms of myotonic dystrophy and is not going to be at risk of having a child with type 2 myotonic dystrophy. And then the range of disease-causing repeats for type 1, anything that is 50 or greater would cause disease for those CTG repeats for type 1. Then the larger that repeat becomes, typically the more severe and the earlier the age onset of symptoms would be. For type 2, really the only specific number that is relevant for causing disease is anything that's 74 or greater. So if your number is anything more than 74, that person is very likely to eventually develop minor symptoms of myotonic dystrophy type 2. We can't really predict anything beyond that in terms of what those symptoms are going to be or what the specific first symptoms are going to be and what age they're going to be. And so in my experience, laboratories typically do not report out the specific size of any repeat. They'll just, if it's larger than 74, they'll just say that they found a repeat that's larger than 74 and may just leave it at that because there isn't any, it's not very useful to have to measure the specific size beyond that. So that's, again, an important distinction. See congenital myotonic dystrophy in families with type 2. I'm sure many of you have met with and talked to families that have had children and other relatives with congenital myotonic dystrophy. Obviously, it's a very significant disease and often has many things that distinguish it from maybe your average adult onset case of myotonic dystrophy. And it's just not something that we see in type 2 myotonic dystrophy, thankfully. And then just to make sure that we're all up to speed on the inheritance pattern of type 2 myotonic dystrophy, similar to type 1, we call this autosomal dominant inheritance. So again, autosomal just refers to the idea that males and females are equally likely to be affected. Somebody's biological sex or gender really is irrelevant when it comes to the risk of being affected or the risk of passing this on. And then dominant refers to the idea that because for the vast majority of genes that we have 2 copies of each gene, one from mom, one from dad, in order to be at risk for developing a dominant condition, only one of your 2 copies of a gene needs to have a change to be at risk of developing the disease. So in this figure example here, this is showing 2 parents, one that does not have myotonic dystrophy, shown by the 2 pictures of the 2 chromosomes on the right, and then one parent that does have myotonic dystrophy, and it's shown by one of the 2 chromosomes has a red band instead of a white band. So that red band presumably is referring to a copy of this CNBP gene, but has a repeat that is larger than 74 repeats. And so what happens is when that parent with myotonic dystrophy type 2 goes to have children, so these are gametes, these refer to the sex cells, so the sperm or the egg. About half of their sperm or egg cells that they pass on would have that gene expansion, and the other half would not. This is really showing. So this is showing that at conception, the person with DM2 would have that child would have a 50% chance of inheriting that change, that DMP or that ENBP expansion, than a 50% chance of not inheriting that expansion. So a little bit more about the genetic test for DM2. So this is a really important point, and I've seen it happen too many times where someone believes that they have had a genetic test for DM2 and actually they have not. I've seen this for DM1 as well. Unlike many other muscle diseases that may well have a genetic cause, not all muscular dystrophy genetic tests are going to actually test for myotonic dystrophy, including DM2. So genetic testing for this condition requires a very specific type of test and method. Words to look out for in terms of the method that is being used is something called PCR, which stands for polymerase chain reaction. Another method that is not as commonly used today because it's typically more expensive and it doesn't really help all that much beyond what PCR could do. It's called Southern blot. With a few specific exceptions, genetic testing for DM2 needs to use some sort of technology that utilizes PCR or Southern blot testing. When it comes to a test that is using something called sequencing, if that is the method that is described on a genetic test report, sequencing is really not a helpful strategy overall for myotonic dystrophy for either type. When you're measuring the number of these repeats, whether it's the triplet repeat in DM1 or the tetranucleotide repeat or the 4-letter repeat in type 2, sequencing tests, due to their own limitations, they're not able to reliably detect the presence of an expansion. So you really do need to use a specific type of test utilizing typically PCR to detect the change or rule it out for type 2 myotonic dystrophy. There's, that being said, several different commercial clinical laboratories and academic medical laboratories that are able to test for DM2. The cost of this testing typically varies, but has significantly dropped over the last 10 to 15 years. Whereas today, that might be around maybe $250 to $500 at most. I would say in 2025, if let's say insurance did not cover the cost of testing for whatever reason, some laboratories might be able to cap the maximum out of pocket cost at a number that might be around $300, $350. So again, there's going to be some variability, and I always hesitate to go into too many specifics when it comes to billing for genetic testing because it's really a moving target. What we might understand at one point, a laboratory might decide to change their billing policies a month later. So I don't want to give any sort of complete assurance or specific information beyond that. But overall, it tends to be in that ballpark price range. And depending on someone's insurance, may or may not be covered. So I wanted to go over a couple example test reports. And so this is just something that I think can really help you make sure that the type of genetic testing that you or your family members are undergoing is the correct type of testing. Okay. So this is an example of a positive result for a person with type 2 myotonic dystrophy. So I'll point out a couple of things on this report here. It lists the name of the gene, the NBP, and the type of myotonic dystrophy type 2, and then it's showing that this is a positive result. So it lists the gene here again, and I've highlighted this in yellow. The inheritance pattern, as we've discussed, it is autosomal dominant, the nature of this condition. And then, importantly here, this is what's specifically telling us that this is a positive result. So because almost all of us are going to have two copies of this gene, almost all of us are going to have two different numbers of repeats. Now, again, they may or may not actually clarify what those numbers are, but in most cases they do not. So this is showing that one of the two copies of this gene has more than 75 repeats. The other copy of this gene has fewer than 26. And so it's purely the gene copy that has more than 75 repeats that is causing that person's symptoms. And the laboratory interprets this as a pathogenic variant or a genetic change that causes disease. And if this person had children, they would have a 50% chance of passing on the gene copy that also has the more than 75 repeats, in which case that offspring would inherit type 2 myotonic dystrophy, and then a 50% chance of passing on the copy of the gene that has fewer than 26 repeats. And assuming that the other parent does not have myotonic dystrophy, that child would not be at risk of developing symptoms of DM2, nor could he or she pass that on to the next generation. Okay. This is an example of a negative result for DM2. So a little bit of a slightly different test that this person actually underwent. And I'll point out that this is someone that perhaps we didn't actually know if either form of myotonic dystrophy was in the family. Maybe this person might have had some concerning symptoms where we weren't entirely sure if they had myotonic dystrophy or not, or if it was a different condition. And so this person was actually underwent genetic testing that tested for both types of myotonic dystrophy. So it was a test that was 2 for 1. It included the repeat expansion for type 2, as well as the repeat expansion testing for type 1. And so this is showing that there were 2 different repeats that were both measured to be fewer than 26. Again, they don't specify the exact number of repeats. They just say that both copies of this gene had fewer than 26. And then they classify those changes as quote unquote normal. This person also had a normal repeat length for type 1 myotonic dystrophy. I haven't highlighted it here, but it's shown that they have 5 repeats. Now, presumably, actually, no, for sure, it's interesting, they only mentioned one number. But the reason they only mentioned one number is because this is actually what we call a homozygous gene variant, meaning that both copies of that person's DMPK gene had the exact same number of repeats. So that's why we use the term homozygous there. So this person presumably does not have myotonic dystrophy at all, does not have type 1, and does not have type 2. All right. So to dive a little bit deeper into the different types of results that we could get for DM2 genetic testing, unlike with type 1, where you have a normal gene copy and a premutation, and then you have a disease-causing change that's in the mild range, then classic, and then childhood onset, and then congenital. There's all these different categories when it comes to genetic testing for DM1. This is thankfully a bit simpler. There's really only 3 possible categories of test results for DM2 with some caveats. You have a normal result, you have a borderline, and a positive result. A normal result means that someone has 2 copies of this CMVP gene that have fewer than 27 repeats or 26 or less. Sometimes laboratories would choose to report out this repeat, not in terms of the number of these CCTG repeats, but actually in the number of base pairs. So really what you would do is just take the tetranucleotide or 4-letter repeat and then multiply it by 4. And then that would give you the specific repeat with some caveat. Why some laboratories choose to report it out in number of base pairs instead of number of tetranucleotide repeats, I'm not entirely sure about that. I think it's pretty uncommon to see it reported out in base pairs, but occasionally you might see it from some laboratories. But anyway, anyone that has 2 copies of this gene with 26 or fewer, that's going to be a completely normal result. That person is not at risk of DM2, nor is at risk of having a child with DM2. And then you have a positive result. Anyone that has 75 or greater number of these repeats, or more than 372 base pairs in one of their 2 copies of the CMVP gene, that person is expected to eventually develop signs and symptoms of DM2 if they have not yet already done so. And then finally, I've skipped over this until now, this borderline category. It's possible to have a repeat between 27 and 74 CCTG repeats, or equivalent number of base pairs, something between 177 and 372. I have been a genetic counselor in the neurology department at Iowa for 5.5 years, and I've had at least a couple dozen patients with DM2 that I've found. So I've ordered this testing pretty frequently, and I have yet to come across a borderline result for DM2. I think there's got to be some people that are out there. Maybe some of you might have met someone that's had a borderline result come back for DM2, but I have yet to see it. But it's just something where we know that people with this type of result, if they are found to have it, similar to DM1 pre-mutations, someone with a DM2 borderline result, meaning that one of their 2 copies has between 27 and 74 of these CCTG repeats, that person would not be expected to develop signs or symptoms of DM2. But if that gene copy is passed on, that could expand in the next generation and become larger than that 75 threshold. And that person then, in turn, would develop signs and symptoms. Again, extremely rare. I haven't seen it, but there's probably some rare folks out there with repeat size in that range. All right, so talk a little bit about genetic counseling. So what is genetic counseling? This is really central to what I do on a daily basis. The genetic counseling overall describes the process of helping patients and families understand how genetic information contributes to disease risks and help patients and families navigate the medical, psychological, and familial impacts of all of this information. So when it comes to genetic counseling for DM2, you have several different goals, priorities, but one of the things that we want to do is we want to help individuals make an informed decision about genetic testing that's specific to their own life circumstances in the context of their family. Okay. We also want to make sure that, as I've alluded to previously, we want to make sure that we order the right type of genetic testing, that we order the test that's going to be the most efficient and cost-effective test, and make sure that those results are also interpreted correctly. All right. Another critical part of our role as genetic counselors is we work alongside the neurologist, but depending on the clinic, how the clinic operates, and the logistics of the clinic, we might be playing a central role in making sure that somebody with DM2 that has a new positive result, meaning they've been newly diagnosed, sometimes we're actively involved in making sure that the correct referrals to other healthcare providers are being made. So, depending on the institution that someone is being tested, the genetic counselor might be the main healthcare provider that's making sure that you're getting all of the screening and follow-up care that would be recommended. So making sure that you're being seen by a cardiologist that has some knowledge about this condition, making sure that you are being checked for all the other health risks that we know are associated with DM2, making sure that if you were to ever need surgery or need anesthesia, that your anesthesiology team is informed about the precautions that need to be taken for someone that has this diagnosis. And another important aspect of what we do, which I think is maybe one of the more commonly understood roles that we have as genetic counselors, is to help patients and families with family planning, including discussion about options for reproduction. So, testing during a pregnancy for myotonic dystrophy, or maybe someone is deciding to undergo in vitro fertilization and conceive pregnancies through that means. And we can often play a central role in making sure that someone is being given all of their options that are available, and sometimes making sure that embryos are being tested and utilizing that information correctly to minimize the chance of passing on this condition if a couple decided to use that method for family planning purposes. Happy to answer more questions. I think that's a fairly hot topic in this. So, when it comes to genetic counseling and genetic testing for DM2, but I think this also applies to really any adult onset genetic muscle disease or other adult onset genetic disorder, I like to think about two different contexts in which someone might undergo genetic testing. One of the categories refers to what I call diagnostic testing, and the other category would be predictive or pre-symptomatic testing. So I'll do my best to explain what the main differences are between these two categories and why it's important to distinguish them. So, with diagnostic testing, this is what needs to happen first. So, before the first person in the family is formally diagnosed with DM2, we need to make sure that this is actually the correct diagnosis, right? So, this would refer to somebody that has symptoms. Maybe they've had an EMG that's shown some myotonic discharges. Maybe they've had cataracts, and maybe some other symptoms that maybe have alerted an astute healthcare provider that this person could have DM2 as the cause of their symptoms. So when someone is referred for diagnostic genetic counseling and testing, this is usually going to be a referral that's made by a neurologist or other healthcare provider who already has some suspicion that this patient might have this condition. In these situations, that person often is going to have a family history that might be described as, okay, yeah, there's other people in the family that have had some similar symptoms to me, but maybe they never were given a formal diagnosis. Maybe they were never offered genetic testing. Maybe it was because of lack of access, or maybe it was just to previous generation. There was a lack of knowledge about this condition. Other times, there might be a lack of family history knowledge because of things like adoption, right? Sometimes someone could be adopted and they have no knowledge of their biological family history, but their symptoms are suggestive of this condition. And so that's prompting the neurologist to recommend genetic testing for this disorder. And then there's other times where maybe there's familial estrangement, right? We know that every family is unique and has its own challenges. Some families are extremely communicative and share as much information with each other as possible. Other families, due to things that are often outside of someone's control, there's a lack of communication and awareness. So there might be someone else that has previously been diagnosed with DM2, but when it comes to the person that's being referred, that's developing symptoms, they just had no way of being informed that this condition was in their family. And then finally, when it comes to diagnostic testing, it's often the case that a neurologist or other doctor might recommend that person be tested for several different conditions at one, either at the same time or on a sequential basis, right? So we're still playing detective. right? So we might have to test for type 1 first. We might test for other conditions. But there are some tests nowadays, especially where if someone, let's say, has been diagnosed with myotonia based on their neurological exam or their EMG findings or a combination of those things, they might be offered a genetic test that, as I showed in an earlier example, that might test for both types of myotonic dystrophy simultaneously, as well as some other disorders that can mimic myotonic dystrophy but are technically separate. So that's a bit of an overview of the diagnostic testing context. Now, let's say someone is finally diagnosed with DM2. They have a positive genetic test result. All right. Now we want to make sure we're not putting the cart before the horse. So now we finally found the diagnosis. We've confirmed that this person in the family has DM2. That is the cause of their symptoms. Now, when it comes to not only managing that person's medical care moving forward, but also informing other people in the family about what is recommended for them, now we know exactly what to do, right? We don't need to be concerned about testing other people in the family for type 1 myotonic dystrophy or for other muscle diseases that don't have anything to do with myotonic dystrophy. Sometimes the analogy I use is when we are looking for a genetic answer in someone that has symptoms, but we're not sure exactly what they are, we're pulling a bunch of books off of the library shelf and we are opening up the books and we are looking through the books for that spelling change that might be the cause of symptoms. And if we are successful in finding that clear spelling change, in this case, this tetranucleotide repeat expansion, we bookmark that same page in that same exact book. And then the testing that we can offer to that person's relatives is for that exact same spelling change on that exact same page in that exact same book. So that's what I describe for predictive or pre-symptomatic testing. So this often is going to be a person that maybe has a parent with DM2. This person maybe is in their early mid 20s. They don't have any symptoms, but let's say their mom or dad has DM2. Well, that person could be referred to see me as a genetic counselor by their primary care doctor. Maybe that person is self-referred because they were given this information by their parent neurologist or genetics provider. And then in the same category, there might be just one other family member that's been given a diagnosis of DM2. There might be several people that have been given a diagnosis. But when it comes to this predictive testing protocol, there's at least one person that's already been formally diagnosed. And now we are offering this predictive test that will clarify if this person is or is not at risk of symptoms themselves. And then again, just to emphasize, in the vast majority of cases, as a genetic counselor, we'd recommend only testing for the same condition that's already been diagnosed in the family. There's no need to offer a larger or broader panel unless that person had a more complex family history or they had symptoms that were suggestive of this condition. All right, so I want to talk a little bit about some potential benefits and caveats of testing. One of the most important possible benefits is that this is the easiest and most sure way to get a definitive diagnosis. It might be really the only way to be entirely sure that someone's symptoms are caused by DM2. So that's probably the big one there. But also, as we know, even though we don't yet have a cure for this condition or a way to reverse the progressive muscle weakness and other muscle and other symptoms that we see, and we know that having a confirmed diagnosis can really help clarify screening and medical management recommendations to help keep you as healthy as possible for as long as possible. So probably the most important part of this would be cardiology screening. We know that people with both types of myotonic dystrophy do have an increased risk of certain types of heart problems, namely problems with conducting the electrical signal from the heart, which are sometimes referred to as conduction defects. Anybody with DM2, a possible benefit is having that confirmed diagnosis that might make it easier to get insurance to cover the recommended cardiology screening and some other related points to that. Another possible benefit is that if someone is having symptoms, but we're not entirely sure if it's DM2 or DM1 or something else, if we have a genetic diagnosis, and the only way to do that is through genetic testing, this is the way to clarify if other family members are at risk. And if they are at risk, what specifically are they at risk for? What are their specific risks based on their location in the family tree? Okay. family planning implications. So if somebody is in their childbearing years and let's say they're asymptomatic, they have no symptoms of myotonic dystrophy, but they have a mom or dad that has symptoms. If we have that confirmed genetic diagnosis in that parent, and then this person that's at 50% risk of inheriting that decides to have predictive testing, one of the most common motivations that people have is that they want to know their genetic status because that's going to help inform their choices in terms of family planning. Maybe they decide if they were to test positive, they might choose to utilize in vitro fertilization, right? Which wouldn't be necessary, at least for the express intent of minimizing the chance of passing it on. Because if that person tested negative for DM2, they don't need to be concerned about having a child with DM2. It's not going to skip generations if that person tested negative. And then finally, one other possible benefit of testing might be to help facilitate enrollment into research studies or different clinical trials. Now, there's going to be a lot of variability. Every research study and clinical trials has different inclusion-exclusion criteria. Some research studies might actually allow you to enroll if you are at 50% risk of DM2 based on having an affected parent, but you have unknown genetic status. There are some research studies or registries that might say, yeah, you can participate if you are at risk, but you don't know your genetic status. But there's others that might say, yeah, in order to be part of this research study or clinical trial, you do need to have genetic testing, and we're only going to accept you into this trial if you have a confirmed repeat expansion that causes DM2. So I would say those are a big picture overview of some of the possible benefits of genetic testing. But of course, there are some caveats that are really important to be aware of. So there's some caveats that are specific to the pre-symptomatic or predictive testing context, and there's some that are more specific to the diagnostic context. I think most importantly, and most people have questions about the possible caveats of genetic testing within the pre-symptomatic or predictive testing context. So this is again just to remind everyone, somebody is at risk of developing DM2 based on having a mom or dad that's been diagnosed. And they know they have up to a 50% risk of inheriting this condition, but they have concerns about the risk of genetic discrimination, right? They might worry that this testing could negatively impact them financially. So this is it's a challenging subject in today's day and age where sometimes it seems like the world's a little bit in chaos, right? So we don't want to get into any sort of political conversation. But I will say that in 2008, 2009, a federal law was passed. This is applicable to all of the US called the Genetic Information Non-Discrimination Act, or GINA. And what this law does is it prohibits the use of genetic information, for example, family history information or a genetic test result. It is illegal for that information to be used against somebody by a health insurer or an employer, as long as that employer has 15 employees or more. So very small businesses I believe are exempt, but any relatively small, not extremely small, but small to large businesses are bound by this legislation. So if someone was asymptomatic, but they underwent predictive testing for DM2 and they had a positive result, which showed that they're very likely to eventually develop signs and symptoms of this condition, it is against the law for them to be dropped from their health insurance or to have their health insurance premiums changed, for instance. It would also be against the law for that person to lose their job or to have the terms of their employment affected based on that result. Now, if someone has symptoms already, that's a different story, right? If someone's symptoms are preventing them from carrying out part of their job responsibility, I think that's a little bit separate from GINA. But when it comes to someone that is able-bodied and doesn't have symptoms but has a positive predictive genetic test, it is against the law for health insurers and employers to use that information against them. But that's where that protection ends. So other things like life insurance, long-term care insurance, disability insurance, there's a couple of states in this country, I don't know exactly what those states are on the top of my head, that have passed state-specific legislation that prohibits the use of genetic discrimination by life insurers or long-term care insurers, but it's a very small number of states, and it's only state law. So somebody, let's say, is thinking about predictive testing for DM2, would always encourage them, if they are also thinking about adding to or taking out a life insurance or disability insurance policy, strongly recommend that they do that first before they move forward with predictive testing. Certainly, I am not a financial expert. I'm not a financial counselor. I'm sure many know more about life insurance and long-term care insurance than I do. So my job is certainly not to tell someone whether they should or should not take out any of these products. However, if someone is already interested in doing so and they haven't fully got all those ducks in a row, so to speak, we strongly recommend that they do that first before they move forward with predictive testing. With diagnostic testing, again, a small potential caveat, there's a small possibility of inconclusive results, but I think that's very unlikely, as I've mentioned before, within the context of DM2. And then some other caveats that are applicable to both the predictive context and diagnostic context. Again, we don't yet have a way to prevent or delay the onset of at least most of the symptoms in those that test positive. But then there's other things just to be mindful of. So accessibility, I'm sure some of you have already encountered this. Sometimes it can be challenging to find a healthcare provider who can order and interpret these results. Depending on someone's insurance coverage and their financial situation, there can be some barriers regarding costs. Thankfully, I think those have become less problematic over time, but it doesn't mean that they still couldn't be problematic for some. And then finally, whenever we are dealing with any sort of genetic condition which could be passed on from parent to child, there always can be lots of different emotions that come with that, which are not always easy. Right? Something that's important to be mindful of. A special quick note about DM2 genetic testing in children. Unlike DM1, which can really have an age onset that varies from birth to very late in life, DM2 is really thought to be almost an exclusively adult onset disorder. And because of that, and because we don't have a way to prevent signs or symptoms from developing in people that have the genetic change with DM2, we generally do not recommend predictive genetic testing for minors. And that's because of ethical reasons. We want to make sure that we preserve that child's autonomy to make an informed decision once they turn 18 years of age and are able to provide that themselves. Right. So we want to try to preserve autonomy whenever possible. Now, if and when there was some sort of treatment that became available where it's really important to start it before someone develops symptoms, this might change quite a bit in the future, right? But until we get to that world where there's an intervention that we would intervene in someone under the age of 18, until we get there, we generally would not recommend predictive testing for children at risk for DM2. There's a couple of resources and strategies that we can help with in terms of sharing these results with family members. This is an example of a family letter that I think I helped put together a few years ago. This is also available on the Myotonic Dystrophy Foundation website. I don't have a link on this slide, but I'm more than happy to direct you to it. I was able to locate it on my own earlier today. And so this is a letter that basically says, "Dear family member, someone in your family has been diagnosed with DM2. This is some information about this condition. This is why it might be important for you to bring this information to your doctor so that you can make an informed decision about what type of testing might be right for you. Certainly, no one is obligated to undergo predictive testing if they're at risk. But certainly, if someone is at risk and chooses not to move forward with predictive testing, we would strongly recommend that at minimum they get an EKG to make sure they don't have any cardiac conduction problems that might be an early manifestation of this condition. The other thing that people at risk that choose not to move forward with predictive testing, they should make sure to inform their primary care provider about possible risk of complications with anesthesia. So if someone also is scheduled for some sort of surgical procedure or other procedures that would require sedation or anesthesia, really important regardless of whether that person's already confirmed to have DM2 or if they're at risk but have unknown genetic status, make sure to let the anesthesiology team know about the possible risks so that they can take precautions. Here's a link to an online resource. This is a findaggeneticcounselor.nsgc.org. Feel free to take this information down. If you have a relative that lives in a state that you're not sure if there's any genetic providers that might be able to help order this type of testing, you can visit that website and you can search by region, state, and specialty. And there's a good chance that there might be someone in that person's area that could help facilitate the correct test being ordered. If possible, make sure to share a copy of your results or your affected family member's results with that person so that the genetic counselor or other provider that that relative meets with has all the information that they need to make sure the correct testing is ordered. All right, I think we've got some time for questions. Thank you so much.
First of all, thank you for being here and sharing your knowledge. I appreciate it. I know everybody else does too. My son had it, was tested and confirmed. And so we found the need for me to be tested.
Okay.
And after I got a positive diagnosis, I guess I didn't really pay attention to the repeats at all. Does it pay to go back and look at the test and see what those repeats are and what might I benefit from that?
Yeah, that's a good question. So, assuming this is DM2, correct? Yeah. So, probably not. And this is one of the differences between DM2 and DM1. I think there's also a fairly high likelihood. How long ago were you tested? Okay. I think there's a pretty high likelihood that on your report, they might not have even specified the number of repeats that you had. They might have just said that you have one of your two copies of this gene that has more than 75 repeats. And as long as someone has a repeat that is bigger than 75, it really doesn't matter in terms of that person's prognosis or the risk for other family members if that number is more than 75. So they typically don't bother even measuring it beyond that.
One of our virtual attendees is asking, can you get tested on your own, like without a physician order, if you're trying to get tested but don't want it on your medical record?
Got it. This is a really good question. I think it's a really tricky question. Is it possible to have this testing done and not have it go on your medical record? I think in theory, it might technically be possible. Whether it's practical and whether it's easy to get that done, I'd say probably not, especially because of the importance of seeing other healthcare providers if you did have a positive result. It's a relatively common question because, again, understandably, many people, when it comes to anything regarding genetic tests, there's an understandable level of suspicion and worry that this information could be negatively used against them. If someone were to come to me and say, "Hey, can you walk me through on how I could get this testing on my own?" It would be pretty challenging, even if I made a really earnest attempt to help that person order this testing on their own. I'm not entirely sure if there would be a way for me to help that person do that. Again, in theory, there might be a way to get this done, but I think I've never had any patients do that themselves. I think it's a challenging thing, but pretty unlikely to be feasible for the vast majority of people.
Is there any indication that the number of repeats change generation to generation? And does it go from generation to generation always increasing?
That's a very good question. So, yes, we do know that the number of repeat can and does change when passed on from generation to the generation, but I don't always think that it's always an expansion, right? I think it's more, this is my somewhat limited understanding of it, is that it's pinballs or ping pongs back and forth between a higher number and a lower number, but that lower number is still a number that's more than 75. And so, because of that, we don't see that term that we call anticipation, meaning early or more severe symptoms with each successive generation. That's something that we know does not exist in DM2. So, because of that, there's really not a whole lot of clinical work that's being done to really specify it. And I think one of the research questions that there's a lot of really brilliant people out there that are trying to figure out is why is DM2, why does it have the variability that it does? We know what accounts for a significant amount of the variability in DM1, and that is the size of that repeat. It's not the only thing that explains the variability, but it's certainly one of the biggest pieces of that puzzle. We know, on the other hand, families with DM2, you might have two siblings that both test positive. One develops muscle weakness in their mid-20s. The other one doesn't develop anything until their 50s. So what explains that, right? We haven't fully understood that yet, but we don't think it has much to do, if anything, with that specific repeat size.
So, if I understand you correctly, my wife has DM2. If both my kids don't get it, does that mean their kids would not be at risk?
Correct. Yep. If your wife has DM2 and you have two children, and if they both had a predictive genetic test that was negative for DM2, meaning that for both of them, both copies of that CNBP gene have fewer than 27 repeats, they are not at risk of symptoms, and they couldn't have a child or any subsequent generations at risk either.
Thank you.
Yeah, absolutely.
You may have addressed this, but
Mhm.
the number of repeats, is there any correlation between that and the severity of symptoms?
Yeah, to the best of our knowledge, not really. Now, again, maybe there's some really weak correlation that was found in one study at some point, but I don't know if it's been verified in the subsequent studies. And I think overall, the cumulative evidence that we have really doesn't show much of any connection between repeat size and severity of symptoms or age at onset.
Okay, thank you.
Thanks everyone for your questions and your participation.